Hello and welcome to today's webcast titled ECLA Symposium, Myopia Control 2021 conference call. We have just a few announcements before we begin. The slides will advance automatically throughout the presentation. If your screen freezes or the slides do not appear to be advancing as they should, please try exiting and restarting the session, as it may be an issue with your connectivity. You can submit a question at any time using the Q&A box located on the bottom right-hand corner of your screen. To enlarge the slides, you can click on the Maximize button in the upper right-hand corner of the slide window. And now I would like to turn the call over to Dr. Bruce Koffler. Dr. Koffler practices in Lexington, Kentucky. Please go ahead.
Thank you very much. Welcome to both our national and international colleagues. We're very excited today to be presenting a broad spectrum review of myopia control. Our first speaker is Deborah Jacobs, who's the Associate Professor of Ophthalmology at Massachusetts Eye and Ear Infirmary. Debbie's going to speak on epidemiology and mechanism, what you need to know. Debbie, thank you for being here with us this morning.
Thank you, Bruce, for that kind introduction, and to ECLA for inviting me on the program, and to our sponsors for making this program possible. Well, my topic is epidemiology and mechanism, what you need to know. I'm not particularly an expert on that topic. I'm a contact lens specialist, among other things, but I was privileged to serve on a special task force assembled by the American Academy of Ophthalmology nearly 2 years ago. This task force was led by Richard Abbott and Donald Tan, who are international experts. They brought along a crew of other international experts and representatives from the American Academies of Family Physicians, Optometry, and Pediatrics. In this task force, we focused on how to reduce the global burden of myopia by delaying the onset and reducing myopic progression in children. And I was a participant, and much of this talk is developed from that white paper. You can find that white paper published in the Academy's Blue Journal, Ophthalmology. Basically, we had a problem emerged from the Far East 20 years ago. By a decade ago, it was apparent that in East Asia, the prevalence of myopia was approaching 90% school-age children. And you can see here the trajectory of the prevalence of myopia over the last century in Hong Kong, Taiwan, Singapore, and South Korea, going up to over 80% in those different nations. But the problem is the Far East issue, and during that same time period, about 10 to 20 years ago, it was found that in the U.S., there was a marked increase in the prevalence of myopia in comparing two cohorts a generation apart. A study of successive cohorts of enlistees in the Israeli army showed a marked increase, again, over a similar time period. And even up near the Arctic Circle, a study of the Inuit showed huge change in prevalence in 2 generations. The most came most recently out of South Korea, where there was a 96.5 prevalence among 19-year-old male conscripts for military service, with 21.6% prevalence of high myopia. The group from Brian Holden, rest in peace, is now published a projection of what the impact of myopia will be in a global projection to the year 2050, showing a steep increase in the number of people with myopia, and an increase not quite as steep, but still significant as far as high myopia. So this is a global issue with big implications, which will be discussed later in the program. Besides the epidemiology, I'm tasked with discussing the mechanism. And it's believed that there are 2 components that go into the epidemic. One is genetic factors, with East Asians at particular high risk, but certainly people of other genetic descent are not protected. Parental myopia also increases risk. Environmental factors that figure in include urbanization and increased outdoor time, which seems to have a protective effect in reducing onset. Other factors that likely contribute but have not been as emphatic in their emphasis are near work, years of education, studious activity, and screen time. For myopia prevention, it's pretty clear that there is a two-phase component to the myopia problem. The cue to generate myopia kicks in early by age 6. That's called the myopiagenic cue. That's because by age 6, most eye growth is complete. That is, the 6-year-old eye is nearly as large as the adult eye. But something goes wrong in myopia, and the cue to continue growing kicks in. There's good evidence that there's an inverse relationship between time spent outdoors and the risk of myopia onset. That is, somehow outdoor time shuts off the switch that makes the eye grow. So the question is, can we avert the cue for myopia? That is, can we make sure that switch happens? And that's probably going to require a public health or population approach. And our best understanding now is that light exposure, bright light exposure in the early years, outdoor time, is important in turning off that switch. Now, to control myopia progression, that's a different problem than myopia prevention. There's less evidence, but some, that outdoor time slows progression. The question is, though, once progression is cued, can we modify it? And although that may respond to public health approaches, it's also amenable to an interventional approach. And the interventional approaches that we know something about, and we'll hear more about this morning, are the optical approaches and the use of pharmacological agents. Again, these are to slow progression. There's less evidence that they have a role in stopping the cue. Well, what's the mechanism, the mechanism for optical control of progression? It's thought from the work of Earl Smith that peripheral hyperopic defocus is likely contributory. And it's this peripheral hyperopic defocus mechanism that forms the basis, at least in part, for the light methods and certainly for the optical methods. This is represented diagrammatically in an adaptation from Earl Smith here. And you can see the black arrow shows appropriate focus distribution at the retina. The red arrow shows the peripheral hyperopic defocus. That is, the image plane is behind the retina. And if you add peripheral plus power, you can swing that in, and that's what the blue arrow shows. Light increases contrast, which could generate the appropriate signal despite defocus. And so light may interact with this optical method in that way. As far as progression, there's little evidence that excess accommodation contributes to progression. The antimuscarinic agents work, but not by blocking accommodation. There are several biological mechanisms by which these muscarinic mediators have been postulated. They include dysfunction of retinal signaling, a change in the RPE signal from the retina through to the choroid, retina to the sclera through the choroid, reduced choroidal thickness, or increased scleral thinning. All of these may be the way by which atropine and other antimuscarinic agents take effect. Indeed, for treatment of or control of myopia, we have a failure to emetropize. Emetropization is a normal process that's endogenous to the eye. There can be homeostatic failures that are primary, that is a failure to stop eye growth at age 6, and there can be secondary homeostatic failures where there's a failure to emetropize exactly. The best treatment may vary with the target, that is the age of the subject. There's emerging evidence supporting outdoor time, pharmacological agents, and optical intervention, and we'll hear more about all of them through the course of our program. In summary, in order to control myopia, we're going to have continued study of populations, mechanisms, and treatment. Thank you very much. I'd like to acknowledge ECLA, the Academy, and my family.
Well, good morning, good afternoon, good evening, everybody.
Thank
My name is
you so
Jason Nichols. I'm a Senior Associate Vice President for Research and Professor at the University of Alabama at Birmingham. I'm also the editor of Contact Lens Spectrum, and I'll speak to that as I proceed through the talk today, which is called Global Trends and Controversies in Myopia Management. Before I get too far along, I'd like to thank the leadership of ECLA and CLAO, President Jane, Christina Prescott, who's organizing this symposium this morning.
Thank you so much for
It's
being
indeed
here.
an honor and pleasure to be here presenting with you today. Before I get too far along, I'd like to present my financial disclosures as such. Content disclosures, this lecture was prepared independently by myself. If I do speak about a product, I'll speak about it broadly. And I'd also, again, like to acknowledge Contact Lens Spectrum. As you'll see, I'll draw on some of the market research as it relates to issues that we'll speak about today. The global myopia management market is potentially huge, and we've heard about the epidemiology of myopia earlier from Debbie Jacobs. I think the potential of the market is just massive. We'll see emerging markets come forward. We'll see new treatments like spectacles have a major impact, and possibly even in the future, new cures with a perhaps genetic basis. Just to give you some perspective, the global contact lens market is approaching about $9 billion today. And you think about myopia management beyond contact lenses, you've got atropine, other pharmaceuticals, and potentially spectacle lenses on the horizon. When we ask our readership in Contact Lens Spectrum, are you actively practicing myopia control in your practice? 45% of practitioners today are saying that they are indeed. We ask them what type of contact lenses are they using as such, and about half will say soft multifocals, half will say orthokeratology. When we ask about also the use of contact lenses and atropine, for example, or combination approaches, practitioners are actively using these as well. And I'm sure others will talk to the efficacy of these in other aspects of the program today. When we ask our readership which topics are most important for us to cover in the upcoming year, over half said myopia management was really where we needed to focus in the next year. A lot of interest in myopia management as well. When we ask specifically about the largest potential growth area in a contact lens practice in 2021, the first was daily disposables, but that was closely followed by myopia management in terms of where people anticipate their contact lens practices growing in the future. When we ask about trends in specialty gas permeable lenses, so your spherical corneal lenses, your scleral lenses, multifocal lenses, one thing that we saw going from 2019 to 2020 was a large jump in corneal reshaping lenses. So perhaps about 5 or 6% said in 2019 that they were fitting in that category. We saw double that in 2020 with corneal reshaping, in particular as it relates to use in myopia control. When we ask practitioners, where are you most likely to prescribe orthokeratology contact lenses, clearly you can see that they say it's in pediatric and teen myopia control applications rather than adult sort of temporary reductions for temporary reductions in adult refractive error. The other thing I want to remind folks is, aside from contact lenses and pharmaceuticals, you've got spectacle lenses on the horizon with unique designs. We're seeing them approved in other markets of the world to slow the progression of myopia. So spectacles are certainly on the horizon for us as we think about myopia management. A lot of interest scientifically in myopia management. In 2019 in IOVS, we published a series of International Myopia Institute white papers on myopia, all aspects of myopia, from defining and classifying it to experimental models, to genetics, to clinical trials, industry guidelines, and the like. So a lot of scientific interest, obviously, in myopia and its management today. As you heard from Debbie Jacobs, the prevalence of myopia is just massive. In 2010, we've got nearly 28% of individuals affected by myopia. In 2050, we predict that there will be nearly 50% of individuals affected by myopia. So again, coming back to the market, there's a significant interest in the market and obviously a need in the market to look at myopia and myopia control. I want to switch gears now and talk a little bit, moving from trends into sort of some issues, ethical issues and controversies that we might think about. And I'm certain that these will come up in other parts of the program today in more detail. But I want to kind of highlight maybe the top 5 or 6 that might be relevant today as we think about myopia and its management. The first of which we might think about is myopia a disease? Sort of a basic question, but I think it's fundamental to the way we think about myopia and its management. When we ask practitioners in our readership, is myopia a disease? You can see in 2014, about a little more than 11% said yes, they think it's a disease. However, 88, 89% said that they did not think myopia was a disease. Fast forward, 6 years later, when we ask our practitioners, is myopia a disease? We have nearly 45% saying, yeah, I think it's a disease, and much less saying, no, they don't think it's a disease. I think it's important that we think about myopia in this context. You think about just a classic definition of a disease. You think it's a disorder of a structure or a function in a human, animal, plant, one that produces specific signs and symptoms or that affects the individual as such, or the function as such. So I very much think of myopia or refractive errors in a general sense as being a disease. The next controversy that I want to lay out and think through or issue is, what is our ethical responsibility to treat myopia progression today? As practitioners, do we have such a responsibility? I think that we're seeing the answer become firmly yes. You can see in the international myopia reports, and particularly the industry guidelines, they suggest that there's a burden of responsibility on the practitioner to be fully cognizant of risk factors that the patient may have, the implications of progression of myopia, what this means, what the risks and benefits are, and to provide appropriate advice and care to the patient. So this was recognized in the IMI report. We're also seeing other organizations adopt such sort of resolutions and standards of care. So, for example, the World Council of Optometry passed a resolution earlier in 2021 that speaks to the importance of there being 3 main components in myopia management: mitigation, measurement, and management. And it advises optometrists, eye care practitioners to incorporate the standard of care for myopia management in their practice. Likewise, in late 2020, the American Academy of Ophthalmology is leading a global task force to address the myopia epidemic. It includes the American Academy of Family Physicians, American Academy of Optometry, American Academy of Pediatrics as such. You can see the broad sort of 3 global areas of focus for this task force, again, emphasizing the importance of us thinking about managing myopia as being a standard of care. Another topic that I think is really important and relevant is sort of thinking about what is important in terms of considering clinical significance in managing myopia. What really matters? And if you think about why does myopia management matter, increased myopia is associated with poor visual acuity, poor visual disability, dependence on refractive correction. Also, myopia management can improve the risks associated with other ocular comorbidities, glaucoma, cataract, retinal detachment, myopic maculopathy. In particular, some colleagues, Mark Bullimore and Noel Brennan, published within the last year papers showing improving that slowing myopia by 1 diopter should reduce the likelihood of a patient developing myopic maculopathy by 40%. So I think it's important that we think about every diopter matters for these patients. Another controversy to think about in the field is axial length measures. Are they necessary? Are all practices equipped as such to measure axial length? When we ask practitioners about the importance of measuring axial length in myopia control, 60% said it's imperative, 40% said it wasn't. We're seeing that the IMI, in terms of the clinical management guidelines, recognizes the importance of axial length measures, but sort of says if it's available, such that recognizing that not all practices are equipped to measure axial length as such. And then also, this is a huge topic, which therapy for myopia management do you believe is the most efficacious? So we ask practitioners what they feel is most effective, and most will say it's a combination of atropine and contact lenses. However, we've still got a lot of scientific evidence. This figure provided to me by Jeff Walline shows various treatments that have been used, from spectacles to pharmaceuticals to various types of contact lenses. A lot showing efficacy, a lot still to learn, and we'll address this in greater detail in other aspects of the program. The last controversy I'd like to point out is the question of where is the FDA or other regulatory agencies in clearing and approving treatments for myopia management, in particular contact lenses. And I think the question is that now that we have at least one soft multifocal, orthokeratology approved for myopia control or management, and many more on the horizon. And we're excited to see these come forward. So with that, I want to again thank the organizers of the program today for inviting me. I really appreciate it, value, and hope you walk away with some clinical pearls as it relates to your myopia management in your own practices.
Well, Jason, thank you very, very much. I'm sorry, but I didn't get the audio on that presentation, and I think others did not as well. So if possible, if that's a recorded video, then perhaps we can replay it at the very end of the meeting so we all can listen in. I would like to continue on with Maria Liu, who's an associate professor of clinical optometry and vision science at the Berkeley School of Optometry. Maria will present on how to get started, how to assess progression, and equipment needs. Maria, thank you for being here with us.
Hey everyone, my name is Maria Liu. I'm from UC Berkeley School of Optometry. It's my great pleasure to be part of this exciting symposium. The topic I'd like to share today is myopia management, how to get started, how to assess progression, and equipment needs. This is my financial disclosure, and I have no commercial interest in any products I'm mentioning today. There are 4 types of equipment that I think are critical in successful and reliable management of myopia in the long run. And the first type is autorefractor, and they're fast and convenient and a lot more objective and repeatable than subjective refraction, as well as retinoscopy, especially in pediatric population. And for those who are doing a lot of OrthoK treatment, autorefraction compared to any other refractive technique is much less dependent on lighting and pupil size. The second type is the optical biometer, which offers a very precise and a longitudinal monitoring of the change of axial length. And they also provide reliable measures of white to white, which is a form of a horizontal corneal diameter measure, but a lot more repeatable and comparable across different biometers. The third type of instruments is a corneal topographer. Again, this is critical for those who are doing a lot of OrthoK treatment, and it provides an overall depiction of the corneal contour, but also giving a lot of detailed information in the mid-peripheral and the periphery cornea, which is highly critical in guiding any specialty contact lens design. The last type of equipment, which is largely overlooked by many practitioners, is the dynamic pupilometer. They can be a standalone pupilometer, but also mostly included in many of the optical biometers. And the dynamic measurement of a pupil behavior is very important in understanding the visual performance by multifocal contact lenses and OrthoK, but also predicting the severity of the side effects in low-dose atropine treatment and offering some insights in understanding the potential interactions in the combination therapy. Autorefractors are very fast and convenient to use, but more importantly, they serve as a very critical role in OrthoK exams and follow-ups. And most of the autorefractors offer a constant sampling area. This is contrasting to retinoscopy, which is highly dependent on the pupil size. And comparing to any other refractive technique, autorefraction is much more reproducible and is not subject to a lot of inter-examiner variability. And most of the clinical trials evaluating the anti-myopia efficacy reported refraction with measured by autorefraction. So having that data offers great comparability in the findings reported by the clinical trials. And more importantly, if you take a look at the topographical changes, contrasting that from a refractive surgery versus OrthoK, you can appreciate that the treatment area offered by OrthoK lenses is not nearly as uniform as compared to that after LASIK. And more importantly, the central area is being flattened the most, followed by a significant angular correction or a lot of asphericity, even in the central treatment area. So this non-uniform treatment is making the subjective refraction or retinoscopy very noisy. And because if the pupil size or measurement is done under different pupil size, especially when the paracentral steepening is being sampled through the retinoscopy, we're getting a lot of scissoring effect, and the reproducibility is dramatically reduced. And so for that reason, auto-refraction is a lot more comparable over time, and that's less dependent on the lighting and pupil size. The second component, which is essential in the long-term myopia management, is ocular biometer. And depending on different assumptions on the optical media, the posterior corneal shape, index of refraction of a crystalline lens, or whether the measurement is done along the optical or visual axis, we may have small discrepancies between the axial lengths measured with different ocular biometers. In terms of the instruments available to measure axial length and other optical or biometric features, they can be generally classified as an A-scan technology as well as interferometers. And for the currently available high-frequency A-scans, they tend to offer a precision in the scale of anywhere between 50 to 100 microns, and versus for optical biometers, they are in the precision is in the range of 10 to 20 microns. However, the precision reported by the manufacturers may not be the actual clinical reproducibility, especially if it's done in pediatric population. With the precision is usually reported with the same instrument with a proper calibration, very experienced examiner, and very highly cooperative patient with very clear optic media. And if any of those factors are not hold, we may see a much larger clinical reproducibility or the range of variation as compared to the 10 to 20 microns reported by the manufacturers. Although the measuring of axial length is becoming less invasive and more convenient, and many children in the age range of 4 to 6 years old are able to get a reliable axial length measure, the interpretation of the axial length reading is actually not as straightforward as we assumed. And more specifically, the axial length elongation actually has two components. The first component is related to an age-related or a physiological development. And the second component is related to a visually induced growth, which cause a myopic shift in the refraction. The depiction of age-related axial elongation is very nicely reported in a recent study published in 2019, which involved 1,300 Singaporean children and with an observational period of 5 years. And some of those children remained as persistent emmetropes throughout the whole 5-year period, which is denoted in the black line here. And this group offers very valuable information in understanding the natural physiological axial elongation without a refractive impact in the myopic direction. Some of the children are already myopic at the beginning of the study, and the rest became myopic somewhere in the middle of the observational period. Those who became myopic during the cohort study also provided valuable information in understanding the abnormal ocular growth before and after the onset of myopia. There are two striking results I'd like to share with you here. Number one, we can see from that black line on the right side, in this persistent emmetropic group, we see this small but clinically significant axial elongation all the way up to the end of the observational period. This is what we considered as the physiological axial elongation. And on top of that, from that, the group that actually became myopic at age 10, their axial elongation at age 8, which is 2 years preceded to the refractive onset of myopia, is already 3 times faster than their age-matched persistent emmetropic group. So this is suggesting that measuring axial length starting at the refractive onset of myopia may not be early enough to capture the start of the abnormal axial elongation. And instead, we should start taking the baseline axial measurement as early as possible and look at the changes over time. Moving on to the third type of instrument, which is critical in the myopia management, which is a corneal topographer or tomographer. Both of them offer additional information beyond central corneal K readings, especially in the mid-periphery and far periphery cornea, and in guiding specialty lens designs, but they are using totally different algorithms in understanding the front surface curvature and the peripheral elevation. And depending on the instrument you use versus the instruments GP manufacturers use to develop their guidelines, if they're based on different brands or different platforms, the information may not be quite comparable. And so here I'm showing you some data comparing the agreeability between the K readings, the corneal eccentricity, and the peripheral elevation information measured with a placebo-based topographer plotted on the x-axis and a tomographer on the y-axis. As you can see here, even for the K readings, they're not completely agreeable, but moving on to eccentricity and the elevation data, you can see the two types of instruments really have very poor agreeability. So this is, again, a reminder that for those of you who are doing a lot of OrthoK feedings, and for the manufacturer's guideline, you want to be aware that if it's developed under a different brand or technology, it may not be readily applicable to your decision in selecting the specific designs of the OrthoK lenses. The last important component in myopia management is the dynamic pupillometry. This has been largely overlooked by many practitioners, and instead, many practitioners only measuring a static pupil size. But beyond just the baseline pupil size, there are a lot of other features related to pupil behavior, such as the latency responding to a pulse light stimulus before the pupil constriction, the amplitude of the constriction, as well as the velocity of the constriction. They all offer valuable information in guiding OrthoK and multifocal designs, as well as understanding for pupil decentration or angle kappa, how is that predicting the visual performance of the lenses, as well as their potential interaction in the imposed defocus to the retina. And related to the low-dose atropine treatment, we now know that the baseline pupil size is a very poor predictor of the severity of the side effects, such as light sensitivity or near blur. So are there any other features offered by the dynamic pupillometry that are more predictive in the severity of the side effects, especially when we're trying to push for a slightly higher concentration in the atropine for chronic use? Can we actually use any of the features measured with dynamic pupillometry as a surrogate marker for the ocular pharmacokinetics, the amount of the drug absorbed and its pattern of elimination? Although we know ciliary body is not the target site of action for low-dose atropine in myopia control, nonetheless, its absorption to the anterior chamber may be a surrogate marker for the actual amount being absorbed into the posterior structure. Lastly, with recent studies reporting potential synergistic effect of an optical treatment combined with low-dose atropine, with one of the proposed mechanism as low-dose atropine potentiated the optical impact with a slight pupil dilation, understanding pupil behavior would definitely be very useful in teasing out the detailed mechanism in this synergistic effect of the combination treatment. So in summary, there are 4 types of instruments that are critical in the long-term myopia management. Autorefractors offer fast and reliable refraction, which is especially important in pediatric population. Because of its ease convenience, it's also very useful in identifying any preclinical myopia, meaning the absence of age-appropriate hyperopic buffer. And for those patients failed the quick screener with autorefraction, detailed exam is necessary with a cyclopedia. And the second component is the early establishment of an axial length profile, preferably using an optical biometer. And it's essential for us to understand the individual's physiological ocular growth, preferably before the refractive onset of myopia. And with that, we're able to understand better the rate of a myopia progression and axial elongation, and so that we can reliably quantify the anti-myopia efficacy. For those who are doing a lot of specialty OrthoK feeding, corneal topographer is an essential instrument, but be aware of the platform or technology differences in terms of the information such as corneal eccentricity as well as peripheral elevation analysis. Lastly, dynamic pupillometry should be added as a standard of care in understanding the visual impact from multifocal lenses as well as OrthoK treatment, but also in guiding the low-dose atropine, the concentration of low-dose atropine, and understanding the potential synergistic effect from an optical combined with a low-dose atropine treatment. With that, thank you very much for your attention.
Maria, thank you very much. That was terrific. I would like to next introduce Michael Repka, Vice Chair for Clinical Practice, Professor of Ophthalmology and Professor of Pediatrics at the Johns Hopkins University School of Medicine. Michael will speak on atropine trials and their current status in the U.S. Michael, thank you for being with us here today. We very much appreciate it.
Hello, I'm Michael Repka, and my topic this morning is to cover myopia control trials using atropine in the United States. I'm at Johns Hopkins University in Baltimore. I'm a consultant for the American Academy of Ophthalmology. I have grant support from the National Eye Institute. Pertinent to this conversation is that I chair a PEDIG study of myopia control with low-dose atropine, funded by the National Eye Institute. I also serve as a consultant for Alcon, Luminopia, and Objective Acuity Limited, projects not related to this content. And it's of course important to remember that topical atropine is not FDA approved for myopia control. We have to remember, and many of the other speakers will hammer this in, that the rate of myopia progression in the United States is not like is being seen in East Asia. One of the few studies we have on this is the CLEAR study from about 20 years ago, which found that progression was about 0.5 diopters per year. And similar data were reported in the COMET study and in the clinical trial assessing pirenzepine treatment of myopia progression. So our US values, our progression rates are lower than were found elsewhere. And in some ways, that makes the clinical trials harder and possibly to have less effect. Pharmacological treatment is not new. Atropine 1% has been used for more than 50 years, with case series supporting its use as effective. However, the side effects of 1% atropine on a daily basis would cause most patients to stop the therapy quite quickly. But it was effective in non-randomized trials, and ATOM-1 used it with as one of its treatments and found it effective, but with many side effects. About 20 years ago, pirenzepine, an M1 selective antagonist, which is used in the treatment of peptic ulcers, was applied as a gel to the surface of the eye. This was an attempt to get the impact on collagen and scleral lengthening without getting the pupillary dilation and pupillary mydriasis effects. It was a randomized placebo-controlled trials, and at 2 years, the mean increase in myopia was 0.58 diopters for pirenzepine and 0.99 diopters for the placebo group. That was a modest result, a little bit less than a 50% reduction in progression, but of concern, 26% of the patients dropped out due to adverse effects. This drop was never labeled or applied for FDA approval. Of course, what's changed the importance of atropine for myopia were the first publications from Singapore, the ATOM studies, which found effectiveness with many doses or many lower doses of atropine, including, surprisingly, 0.01%, which, at least in the Singapore experience, was associated with the best progression inhibition, the least rebound, and the least side effects compared with the other dosages. Interestingly, that project did not show a match between axial length elongation and the impact of the drop on refractive error. Doubling down was the LAMP study from Hong Kong, which was a randomized study which found that children 4 to 12 years of age had a delay in myopic progression with 3 different doses of low-dose atropine, 0.05, 0.025, and 0.01. They've now published results through 3 years. The results at 1 year were certainly surprising, but they did work at all concentrations. They did have a 12.5% loss to follow-up. Unlike ATOM, this study found that there was a dose dependence. The higher the strength, the better the reduction in progression. Those data at 2 years were similar, although the progression did continue, and the 0.05% was doing better than 0.01, again in the Hong Kong LAMP study. At 3 years, the progression has continued in all 3 groups. Again, there's no placebo, so we can't know what's going on with respect to the placebo group. What's interesting is that if you look at the 3-year outcome for the LAMP study with the 0.05% of minus 0.73 diopters, it's similar to what was found in ATOM-2 for the 0.01% dose. Now, if you tuned in for completed studies in the United States, they don't yet exist. There are many issues that have come up with development in terms of outcome measures and monitoring the children on treatment. Do you require a cycloplegic autorefraction? The importance of measuring axial length to see that it correlates with the refractive error change because it's the axial length that we want to see inhibited and not just the cycloplegic refraction. Randomization is, of course, important. 3 years of follow-up on treatment is preferred by the FDA. The studies will have varying washout durations, somewhat varied age ranges, and the refractive error is typically -1 to -6 diopters. So the first study, Myopia Treatment Study 1, which I co-chair, children 5 to 12 years of age, we're using just a single dose of 0.01% atropine with a placebo control. We have a 2-year treatment plan because that's what we could afford. The outcome measure will be the proportion of subjects who show less than -0.50 diopters of myopia progression. We will complete our washout data collection in August 2022, and of course hope to go public with the results shortly thereafter, assuming we have them published. CHAMP is a study of Nevicar's drug NVK002, also in children with myopia. They're testing 2 low-dose atropine concentrations, placebo control. Because it's for labeling, they're going for a randomization for 3 years with the primary outcome on treatment. And they similarly have a primary outcome of the proportion of subjects who show less than -0.50 diopters of myopia progression on treatment, and also expect results in late 2022 with an application to the FDA soon thereafter. Chaperone is another study occurring in the US. It is using 2 doses, -0.01 and -0.1 with a microdose effect, 420 patients, 3 to 12 years of age, so a bit wider than others. There's also safety and efficacy of SYD101 in children with myopia, Sidnexis Corporation's study, 3 years, 2 doses plus placebo, with some crossover, so they end up with 5 groups at outcome, and they're looking for a primary outcome of more than 0.75 diopters of progression. Other studies are in development here. These are by no means going to be the end of the story. Follow them on clinicaltrials.gov. These are expensive to conduct. Access to the right population is difficult, and it may become more difficult with the ability to recruit controls for a long period of time. Just to be complete, there are other low-dose studies going on around the world. In fact, in most countries, you can find one going on at the moment. CHAMP UK is looking at 2 years placebo versus 0.01%. Mosaic is a study in Ireland using 0.01% versus placebo, again a 2-year study. Numerous other studies, as I mentioned, do follow those online. There are important issues for us to consider with low-dose atropine use. Although the side effects have been minimal and typically stinging, those are being collected and will be interesting to see what comes up in the clinical trials. This drug lacks FDA approval, it needs to be compounded, it's not covered by insurance, and is increasingly more costly and less available. And lastly, the durability of treatment is unknown in our population. So in summary, there has been a remarkable growth in interest in myopia control over the last 5 years. Low-dose atropine is being prescribed throughout the United States. And one concern I have, will anyone allow their child to be a control for 2, 3, or more years for future studies of low-dose treatments, as well as other treatments or treatment designs for myopia control? So thanks very much for your attention. Have a good day.
Thank you, Dr. Repka. That was well done. Let us move on to Dr. Siu Lin Lam, who is professor of optometry at the Hong Kong Polytechnic University School of Optometry. Dr. Lam will speak on myopia control with the DIMS lens, 3 years results. Dr. Lam, thank you for joining us and spending your evening with us from Hong Kong.
Good day. I'm pleased to have the opportunity to share with you the myopia control efficacy of the DIMS lens over 3 years. Among animal studies, integration of simultaneous multiple defocus during eye growth determined the ultimate refractive status. By using a minus lens to shift the image behind the retina, the eye compensates for the displaced image by extending the length of the eye. The lens induces a hyperopic defocus. And by using a plus lens to shift the image in front of the retina, the eye compensates for the displaced image by shortening the eye length. The lens induces a myopic defocus for the eye. We hypothesized the natural process of ametropization in human eye is regulated by an equilibrium between the opposite hyperopic and myopic defocus. In our endeavor to identify an effective method, our first approach was a contact lens design and is named as the defocus incorporated soft contact lens, or simply the DIS lens. It is a contact lens with concentric rings that the center zone is for correcting the refractive error. Then there is the first myopic defocus ring of plus 2.5 diopter. Then the rings alternate between the correction power and myopic defocus power. This pattern provides clear distance correction for the wearer and at the same time induce myopic defocus to retard eye growth. The contact lens will move with the eye in all the direction of gaze and therefore maintain the same myopic defocus stimulation. In the 2 years RCT, the overall retardation effect of the DIS lens was 25%. This figure shows the changes in myopia progression and axial length over the 2 years. We did not see any plateau effect during the 2 years. We also noted a dosage effect of the time with myopic defocus exposure. In this figure, we plotted the contact lens wearing time versus the change in ocular refraction. And for children who have worn the DIS lens for more than 8 hours, the retardation effect reached 60%, with a mean difference between the control and treatment group of 0.53 diopter. Of course, we all know there are limitations for children to wear contact lenses. It was an opportunity that we discussed with Hoyer colleagues in 2012 with a common goal to develop a spectacle lens using the same principle. This figure on the right side shows the design of the spectacle lens. We name it the DIMS lens or the DIMS technology because of the defocus incorporated multiple segments. At the mid-periphery of the lens, there are around 400 lenslets of 1 millimeter in diameter and of power per 3.5 diopter, surrounding the central zone, which is for distance correction. The total area between the two power zones is about 50-50 ratio. The fitting and wearing of the DIMS lens is similar to single vision lenses. Those multiple segments are so fine that they are hardly noticeable unless light is shown onto the lens, and that will reveal a shadow with a honeycomb pattern. We conducted a 2-year double mask randomized clinical trial for the DIMS lens, and children were masked and randomly assigned to wear either the DIMS lens or the single vision lens. Psychoplegic refraction and axial length were measured. The primary outcomes were changes in psychoplegic refraction, and the secondary outcome is the axial length changes. Subjects recruited for this trial were Hong Kong ethnic Chinese myopic children aged between 8 to 13 years, and with a spherical equivalent refraction between -1 to -5 diopter. And they have no prior use of any myopia control methods. These two figures on the left shows the 6 months myopia changes and axial length changes over the 2 years. The DIMS group is presented by the green line and the control group is presented by the orange line. It is obvious that the DIMS group had a slower myopia progression and less increase in axial length over the 2 years. Myopia control in the children wearing DIMS lens were 59% slower than those in the single vision group, and axial length changes were less by 60% in the treatment group than the control group. This result is comparable to recent trials in OrthoK and contact lens myopia control, but among the best treatment effect in spectacle lenses. So we conclude that daily wearing of DIMS lens significantly slow myopia progression and axial length elongation in myopic children by around 60% respectively. After 2 years of trial, the visual functions were not different between the two groups. So DIMS lens wear had no adverse effect on the measured visual functions, and this include the distant and near visual acuity, amplitude of accommodation, accommodative lag, and stereopsis. At the end of the trial, we offered the participants to continue the follow-up and lens wear. And this time, all the children were assigned to wear the DIMS lens. The group of children from the control group started to wear DIMS lens, and we retitled this group to be Control to DIMS group. So the same measurement protocol was adopted, and this includes cycloplegic refraction measured by an open field autorefractor and axial length with the IOL master. Children were now 2 years older, and the criteria for the ocular refraction was not applied in the follow-up study. This two table shows the comparison of the subjects' numbers between the 2 years RCTs and the 3-year follow-up study. 75% of subjects remained in the follow-up study. The table on the right shows the third year enrolled subjects and dropouts. At the end of the third year, 65 subjects from the DIMS group completed, and 55 subjects from the original control group switched to wear the DIMS lens completed the 1-year follow-up. Children wearing the DIMS lens continue to show good myopia control effect. The annual changes in myopia progression were on average minus 0.18 diopter, and the progression rate was quite linear over the 3 years. These results could imply that myopia control effect was sustained at around 50 to 60%. And for children who were in the original control group, the myopia control effect was quite significant. From this figure, in the first 2 years, while wearing the conventional single vision lenses, the progression rate was like minus 0.49 and minus 0.38 diopter in the first and second year. But after switching to DIMS lens wear, myopia progression was down to only minus 0.05 diopter for the third year. This figure shows the axial length changes in the DIMS group. Again, very steady and consistent increase in the annual axial length of around 0.1 millimeter per year. And in the control to DIMS group, the third year change was 0.12 millimeter as compared to the first 2 years of 0.29 millimeter and 0.2 millimeter. Children once switched to wear the DIMS lens benefited with myopia control significantly. So in conclusion, for those wearing the DIMS lens for 3 years, myopia control effect was sustained. Both myopia progression and axial length changes were similar to the previous 2 years, and therefore estimated the efficacy to be around 60%. And for the control group who switched to DIMS lens, myopia control effect was present and in similar trend to the age-matched DIMS lens wearers. DIMS lens offered a non-invasive, convenient treatment for myopia management. I would like to declare that the information in this talk is based on collaborative research sponsored by Hoya Corporation, and the DIMS lens is co-developed and patented with Hoya Corporation for myopia control in young children. I would also like to acknowledge the DIMS project team, and thank you.
Thank you so much for that wonderful talk, and thank you so much to all of our speakers, especially for staying on time. And we now have a break. We actually were on the schedule, it says from 8:55 to 9:05, but actually we're going to start again at 9 o'clock just to make sure we give our last few speakers plenty of time, and also have a little time for question and answer possibly at the end, depending on when we finish. I would also like to thank our sponsors, Cooper Vision, Bausch & Lomb, Alcon, Viluma, and Johnson & Johnson. I'll thank them for their support of this meeting. So if everyone wants to get up and stretch and come back to your computer in about 5 minutes, we will start again at 9 o'clock. Thank you so much.
Hello. Hello. Hello.
Okay, thank you all for hopefully coming back. We, like I said, I can do a little bit of a shorter break so we can make sure we have plenty of time for everyone's talk. So we are going to get started with the second half of our speakers. So Dr. Siu Lin is going to introduce Dr. Walline, who will be our next speaker.
Good morning, everybody. I'd like to introduce Dr. Jeff Walline, OD, PhD, Associate Dean for Research and Graduate Education at The Ohio State University College of Optometry.
Thank you for the opportunity to talk today about multifocal soft contact lens myopia control. My name is Jeff Walline, and I'm the Associate Dean for Research at The Ohio State University College of Optometry. I'm also the study chair of the Bifocal Lenses in Nearsighted Kids, or BLINK study, a National Eye Institute sponsored randomized clinical trial to investigate the effects of soft multifocal contact lens wear on myopia control in children. I do have one disclosure to provide, and that is that I received contact lens solutions from Bausch & Lomb to use in the BLINK study. This is my look at the soft multifocal contact lens myopia control literature. And I want to take a minute to just kind of orient you to this particular graph. So along the x-axis, you can see all the various studies where they compared either both myopia progression and or eye growth with soft multifocal contact lenses to single vision, either glasses or contact lenses. You can see that studies vary in length. So this one actually was a 10-month study. These are all 1-year studies, these are 2-year studies, and these are 3-year studies. And that leads to a large variety in terms of the results of these studies. Other things that affect the results of the studies and lead to this large variety is that kids of different ages are actually investigated, different ethnicities, for different lengths of time using different contact lenses. So all of these things sort of lead to that variability. But one takeaway point I want you to take from this is that on average, we slow refractive error progression by about 0.31 diopters and eye growth by about 0.15 millimeters over an average period of 2.1 years. So that's the basic takeaway point from this graph. But I also want to show you a little bit about how to understand this graph and give you a few numbers that I think are important for myopia control. So the way you look at this is we look at the difference in refractive error progression between the treatment and the control for each individual study. And refractive error progression is shown with the black bars. If you look at the top of the black bar and you trace it all the way over to the right-hand axis, you can see that that particular study found that over a 10-month period, those contact lenses slowed myopia progression by 1/4 diopter. They also slowed eye growth by about 0.12 millimeters. So if you look at the red dot and follow it to the left graph, you can see that eye growth was slowed by 0.12 millimeters. And again, the overall average is 0.31 diopters slower myopia progression, 0.15 slower millimeters eye growth over an average of 2.1 years. But the numbers I really want you to take away from this, because it's harder for us to understand what eye growth means because we don't routinely measure it. So if a person progresses by 1/4 diopter, we expect in general about 1/10 of a millimeter of eye growth. And you can see that right here on this graph. Or we usually expect myopes to progress at about 1/2 diopter per year. That equals about 2/10 of a millimeter of eye growth. So the average eye growth for a myope is about 2/10 of a millimeter. Now we know that slows naturally with age, but a good number to keep in mind is about 2/10 of a millimeter per year. And emmetrope's eyes also grow, and they grow by about 0.1 millimeters. So that's just another number you can kind of keep in mind to sort of understand the new way we're talking about myopia control, and that's in how much we can slow the growth of the eye. Now, when we talk about soft multifocal contact lens myopia control, we're really only talking about one design of these contact lenses, and that's the center distance design. And these are two specific center distance design contact lenses. So both of them have the central part of the contact lens that corrects distance vision. And then in this particular one, there are distinct zones of relative plus power with an interceding distinct zone of distance correction that ultimately slows myopia progression. And in this particular one, the center distance design power really becomes relatively more plus as you get out to the periphery, kind of like a progressive bifocal spectacle lens. And so these are two different specific center distance designs that can be used for myopia control, but we should not be using center near designs for myopia control. Those are the ones that are most commonly used to correct presbyopic patients, but they really have not ever been shown to be effective for myopia control. And the studies that have taken a look at the stimulus that we think slows myopia progression, they find that they are not as strong in the center near design, So really you should only use center distance design. And these are some of the contact lenses that are available in center distance design. If you fit contact lenses for presbyopes, you may know that ProClear and Biofinity multifocal contact lenses come in center distance design for one eye and center near for the other. But for myopia control, you want to fit the center distance design or the D lens in both eyes, as opposed to center near in one and center distance in the other. And this is how we think those contact lenses actually work. If we correct an eye with a single vision lens, we of course are trying to put the focus of light right on the fovea to provide clear vision. But because the eye is longer than it is wide, it's a prolate myopic eye, the focus of light in the periphery tends to be behind the retina. If we put that relative plus power in the mid-peripheral part of the contact lens, then we can still keep the focus of light right on the fovea so patients can see clearly. But now we move the peripheral light rays anterior to the retina, and that acts as a signal to slow eye growth. So it's that myopic defocus that we think ultimately slows the growth of the eye. And this is one study that shows that that's probably the case. So some people think that soft multifocal contact lenses slow myopia progression because they reduce accommodative effort or they reduce accommodative lag. But in this particular contralateral study, they put a multifocal contact lens on one eye, the right eye, for example, and they put a single vision contact lens on the other eye, the left eye, for example. And when they did that, they found that the eyes with the multifocal contact lenses progressed more slowly over a 10-month period. They then had the patients switch eyes and put the multifocal contact lens in the other eye. And when they did, the other eye progressed more slowly than the eye wearing single vision. We know that accommodation is yoked between the two eyes. You can't relax accommodation in one eye and not in the other. So if these contact lenses worked by reducing accommodative effort or error, then it would slow the progression of myopia in both eyes. But the fact that it only slowed the progression of myopia in the eye with a multifocal contact lens says it's something about the optical design of the contact lens that's probably slowing myopia progression. And we think it's that myopic defocus that the lens creates that actually slows myopia progression. Now, this is a study using the only contact lens with an FDA indication for myopia control. As a matter of fact, it's the only modality with an FDA indication for myopia control. And we can see significant slowing of both myopia progression and eye growth in this particular study. And this contact lens has that concentric design center distance contact lens. This study was done with a gradient design center distance contact lens. This is the Blink study that I'm actually the study chair of. And we found very similar results. So the two different center distance designs provided very similar results, which you'll see on the next slide. But I think this also provides an important answer to an important question, that is, do you have to prescribe the highest add power in order to get the maximum benefit from it? And this study would indicate that that's true. So a third of the patients were randomly assigned to the highest add power plus 250 add, a third of them to the plus 150 add, and a third of them to single vision contact lenses. And when we did that, only the ones with the 250 add had slower myopia progression than single vision. The 150 add was actually similar to that. And same thing with eye growth. The 250 add was slower eye growth, but there was no significant difference between 150 add and single vision. So ultimately what this says is, in order to get myopia control with these contact lenses, you need to use the highest add power. And so those two studies that we just talked about had very similar results, even though they had very different designs. So our study, the BLINK study, actually slowed myopia progression by about a half diopter over a 3-year period. The other study by about 2/3 of a diopter when you look at the adjusted results. And both of them slowed myopia or eye growth, by about 1/4 of a millimeter. So there really was no meaningful difference, even though the two designs were very different. In our particular study, again, we fit the Biofinity Multifocal D contact lens in both eyes with the 250 ad. And when we did that, we found that if we put the contact lens on the eye that used the distance prescription from the manifest refraction. So we took the manifest refraction, we vertex distanced it, we vertexed it for spectacle lens distance, and then we took the spherical equivalent of that and put that on the eye. When we did, the kids needed an overrefraction in order to provide best vision. And that overrefraction was generally on the order of -0.5 to -0.75 diopters more minus. Now you might be thinking, hey, that would reduce the amount of myopic defocus in the periphery, but David Bernsen actually did a separate study. And in this study, they also found that the average overrefraction required was 0.66 diopters. And when they provided that and measured the myopic defocus in the periphery, they still found myopic defocus even though they provided that overrefraction. And we now know that the 250 ad provides essential myopia progression. So based on that, you want to give the kids best optimal vision. So provide that overrefraction. They should do fine with that. And almost every kid does fine with that. However, if you provide that overrefraction and they still complain of poor vision, then one thing you can consider is reducing that ad power by 1 step. So use a 2+2 ad. If you do that, they might get better vision. But if you reduce it more than that, then they won't get myopia control. So keep that in mind. But not all multifocal contact lenses require that overrefraction. So it depends on the brand that you're using, but I can tell you that Biofinity Multifocal D contact lenses do require that overrefraction. When you do provide those lenses, though, they provide equal vision as do single vision spectacles. So this is 250 ad, the frequency diagram of the visual acuity, where most of these kids got better than 20/20 vision, and there was extreme overlap between single vision glasses and multifocal contact lenses. As a matter of fact, on average, the two visual acuities were both better in 20/20, exactly the same with the same variability. And that's also been shown in other studies. This particular study looked at dual focus or the concentric design and gradient design multifocal contact lens. They found the exact same high contrast distance visual acuity as with single vision glasses. Where they did find a reduction was with low contrast visual acuity, but it was less than a line difference between single vision glasses and those. So it's probably not clinically meaningful. And probably most importantly, the highest incidence of discontinuing contact lenses or corneal infiltrative events is actually in college-age kids. So these younger kids are actually getting more benefit from contact lenses because they get slowed myopia progression and lower risk. So that risk to benefit ratio is in the right direction. So what I hope you take away from this is that soft multifocal contact lenses provide clear vision and effective myopia control. And if you use them, you should use the higher ad power and provide an overrefraction if necessary for that brand of contact lenses. And most importantly, kids can wear them safely. Thank you very much.
Thank you so much, Jeff. And that presentation was so good, we had to hear the beginning of it over again. So apologize for the technical difficulty, but we're going to quickly move on to Dr. Michael Lipson, who is a clinical associate professor of ophthalmology and visual sciences at the University of Michigan. Mike?
Thank you very much for the opportunity to talk about where OrthoK fits into myopia management. Just quickly disclose that. I'm going to go through these kind of quickly, but I want to talk about what's the difference between just myopia management and OrthoK, what we know about OrthoK, what we don't know about it, and what it does for the patient and for the eye, and really where it fits in to an overall myopia management strategy. Now, typically we're prescribing OrthoK to correct for refractive error, and we've seen myopia management take place even though it was not directed directly at myopia management. So with OrthoK, we target correcting the refractive error, and we've seen the lucky side effects. But I think in the future, what we're looking at is specific design modifications that can make OrthoK even more effective in controlling myopia progression. In other words, you don't really prescribe the same spectacle lens for each patient, and for OrthoK, one design will not produce the same effect in every patient. There's significant individual differences in how people respond both subjectively and with topography, and there are a number of things that affect that. So just for example, here's a OrthoK pre and post topography for two different patients wearing the same identical design lens. And as you can see, the treatment zone and the so-called red ring is significantly different size in each of these patients, where you have the same design with the different response in each patient. What we know about myopia and what we know about how OrthoK affects this is really a lot from these myopia papers that were published. And that one of the things that they conclude is that there is a lot of individual variation in this myopia progression. And from the CLEAR studies that were published, they specifically focused on OrthoK, is that we believe that the optical mechanism has to do with the relative myopic peripheral defocus, as was described earlier, but that the total underlying effect is still not totally understood. And the efficacy of OrthoK has been established, that it significantly slows axial length elongation, but we need to have more study on it to really know all of the mechanisms here. But in summary, what we know about OrthoK and myopia management is that somewhere around 38 to 62% slowing of axial elongation, that this effect generally is thought to come from that peripheral myopic defocus, and that there may be some interaction from change in accommodative effort required. We also know that there are numerous studies showing OrthoK is safe. The largest study done on this was showing that there were about 7.7 adverse events or microbial keratitis events during approximately 10,000 years of wear, so about 1 in every 1,300 patient years of wear, compared to overnight wear of silicone hydrogel lenses, where it's more than double that risk factor. So, but we also know that careful evaluation, follow-up with patients, that the potential problems can be minimized with very careful follow-up and careful adherence to compliance on care of the lens. So what it really does to the eye, OrthoK, it thins the epithelium centrally, and it's not by that much, maybe about 10 microns. There's a centrally this thinner epithelium and a ring of thicker epithelium outside of that. The topographic changes we're all very familiar with, but it is not a one-to-one refractive to topographic change, meaning for this example that was shown here, there was approximately centrally about 3 3/4 change in corneal curvature centrally, and that fully corrected this 5-diopter myope. And that has to do with that steeper ring around the central flattened area. Again, the topographic changes that can happen during OrthoK vary tremendously, and there are different ways to look at that through the use of your topographer with tangential versus axial maps. Again, the obvious thing, what it does to the eye, OrthoK reduces refractive myopia and improves vision. So visual acuity, excellent throughout the day, 92% in one study showed 20/25 or better. Another one, 90%. So they're all showing very good vision, but we also know that while it corrects acuity very well, it creates some spherical aberration and some higher order aberrations that can have an effect on the overall quality of vision, but it probably has something to do with the myopia control effect as well. You've seen this slide on previous presentations that OrthoK also creates this relative peripheral myopic defocus. But basically, what it does for the patient is a pretty critical part of this, and there is a questionnaire that I helped develop here with a co-author to basically validate a OrthoK questionnaire to find out how this affects the patient and how it affects overall quality of life. And what we find in patients who are wearing OrthoK is that there's an improved overall vision-related quality of life, mainly because they don't have to wear any correction during their waking hours. But there are other intangibles, such as, better self-image, less activity restrictions, more comfort for the eye during the day, and just overall they're more happy with their vision. Again, these intangibles are pretty important to patients, and it's a very good feeling for them. They love it. Again, visual acuity created through OrthoK is very good, both subjectively. Patients report that they see well as objectively on the studies with overall acuity. So we asked that question many years ago. If you had a choice to wear soft lenses or OrthoK, which would you choose? And we let patients do that. They had to wear each modality for 2 months and switch over. It was randomized presentation. They crossed over. Some of them started with soft lenses. Some of them started with the OrthoK. But really at the end of the study, 68% chose to stay with OrthoK. And in those who were under 3 diopters when they started, 87% chose to stay with OrthoK. Again, during that study, no adverse events occurred. The main reasons that people chose the OrthoK was the less activity restrictions and less dependence on their correction. So really what it does for the patient is a critical thing. It slows myopia progression, as I mentioned before, 38 to 62% axial length reduction. In a large study that was done on myopia management, 16 different strategies were evaluated. OrthoK came in third on that list, only beaten out by Atropine at 1% and Atropine at 0.5%. So on this meta-analysis, it shows OrthoK is slowing axial elongation by about 45%. Again, the mechanism of action is not totally understood, but mostly attributable to this change in peripheral refraction. The first RCT on myopia progression with OrthoK was done by Pauline Cho in 2012. And again, this one came in at about 43% reduction in myopia progression. Some of the new thinking that Dr. Walline mentioned just previously has to do with the overall effect, the cumulative effect of how we reduce axial elongation. We know that the effect varies with the duration of treatment. After the first year, there are changes. It also is variable on a number of factors relative to age or degree of baseline myopia. We also know that kids progress faster when they're younger. So the sooner that we can implement a myopia management plan, the sooner we're going to be able to have an effect and a bigger long-term effect. So a lot of people ask, if you're still myopic, what is the big benefit of this? But by reducing the overall myopia, somebody is still myopic, but they have less visual disability when they're uncorrected if they're less myopic. They have better options later on in life for surgical options, and they have less risk of the impairment due to the side effects of high myopia. A lot of the things that we really don't know about OrthoK and myopia management is why some patients still show progression and why others show absolutely no progression with OrthoK, that the individual differences in their effect. The ideal peripheral refractive profile for myopia management created with OrthoK is not totally known. So we may be able to manipulate that ideal peripheral refraction with OrthoK to make OrthoK even more effective than it is now. So a lot of questions that people always ask on OrthoK is when should I start? When should I stop? I think the starting point should be basically if you see a kid who's progressing in myopia, increasing axial length, the patients who are motivated to really avoid wearing glasses. Age is not a huge factor, but it can be a factor. And kids that are just going to really be compliant with their care. As far as stopping, if your only interest is in myopia management, then you might stop somewhere around 21 or 22. But literally, there's no reason they ever have to stop. If they start in OrthoK for myopia management, they may continue to wear that as an adult. As far as candidacy for OrthoK, you all know the refractive numbers on this, but I tend to look more at the patient themselves and say the ones who are progressing quickly, who are motivated to avoid glasses, and really they're interested in slowing their myopia progression. Really quickly, I want to go through a really pretty ideal case for this. An 8-year-old girl who presents says their vision isn't clear. They're minus 125 in the glasses that they come in with, and they're seeing 20/50. So we update their refraction, find that they're progressed to diopter. The axial length on this girl was 24.5 millimeters. Now, the first option that you might talk about with her would be updating her glasses. The advantages here is that the cost is low, it's easy for the patients and parents, but the disadvantages are they continue to progress very quickly, the glasses may interfere with their activities, and they still risk the myopic complications from longer axial length. So if we speed ahead on this patient, we jump ahead 10 years. Now she's 18 years old and has been wearing glasses that whole time. She's now approximately a 7 diopter myope with an axial length of 27.5. She has a high risk of ocular pathology and some activity restrictions. This second option is an OrthoK patient. You are slowing down her myopia, and 10 years ahead for this patient, she's probably about a minus 375. So, in a 25 millimeter axial length. So, again, the two questions: is there a greater risk for OrthoK treatment or not managing the myopia? And I think overall that it's a lot less. So, in summary, OrthoK provides excellent vision, no need for correction during the day. They have an improved overall vision-related quality of life, and that the myopia management effect is in play 100% of their waking hours, and you can probably start a little earlier. So, again, I thank you for your attention. OrthoK, I think, plays an important role in myopia management and can be very effective and very satisfying for both you and the patient. Thank you.
Thank you so much, Mike. We're going to move on to Dr. Joanne Kang, Director of Cornea and Refractive Surgery, Associate Professor of Ophthalmology at Albert Einstein College of Medicine.
Hi, good morning, everyone. Thank you for the introduction. So I'm happy to speak to you, everyone, today about the complications of pathologic myopia. I have no financial disclosures. So for the complications of pathologic myopia, it can affect the macula, the peripheral retina, and the optic nerve. So we've heard so eloquently some of the other speakers this morning about really the epidemic of myopia and the increasing rates. The visual loss due to complications of high myopia, pathologic myopia, will likely just increase over time due to this rapid growth in number of individuals with myopia. And this is a problem because it tends to affect younger patients. There are high rates of progressive disease with age, which I'll touch upon in a moment. And there's also a high likelihood of bilateral disease in these individuals. So what exactly is pathologic myopia? So we know that high myopia is traditionally defined as a refractive error with a spherical equivalent greater than -6 or an axial length greater than 26.5. But that doesn't necessarily mean pathologic myopia, which is really the development of characteristic pathological changes at the posterior pole that can lead to loss of best corrected visual acuity. So in the background, you can see an image. This is one of my patients with one of the kind of characteristic findings of pathologic myopia. Then there is something called myopic maculopathy. And so there is an international group of researchers in myopia who performed this, meta-analysis of what they call pathologic myopia classification system, where they proposed kind of this uniform system to define what maculopathy is. And the definition is eyes having chororetinal atrophy equal to or more severe than diffuse atrophy. And I will touch again upon this a little bit further. So we heard actually a lot about the pathophysiology, but we know that the pathological changes start in childhood, become more prominent in adulthood. You get this excessive axial elongation, which results in chororetinal stretching and subsequent thinning, which is thought to be due to retinal refocus. And you get a whole cascade of molecular signals that lead to changes in the retina, the choroidal thickness, and scleral growth. We also know that choroidal circulation decreases in high myopia, and you get loss of choroidal vessels, changes in fibrotic changes within the choroidal vessels, and ultimately chororetinal atrophy. So going back to myopic maculopathy, which is the major loss of vision in these patients, there are categories 0 to 4, 0 being no myopic retinal changes, and category 4 meaning macular atrophy. And these categories were defined based on long-term clinical observations that inform progression patterns and risk of choroidal neovascular development for each stage. So I'd like to go through each category individually. So there is a tessellated fundus, which is category 1, which just shows the outline of choroidal vessels easier just due to thinning of the choroid. Then we have category 2 and 3, which is chororetinal atrophy. We have diffuse and patchy. So this is an example of diffuse chororetinal atrophy, and you can see it's kind of ill-defined, yellow-whitish, and you have this characteristic appearance due to marked thinning of the choroid. In contrast, you have category 3, which is more defined. It's kind of this whitish grayish lesions you can demonstrate by the arrowheads here. And this is complete loss of the choroid, and it can lead to progression of loss of the outer retina and RPE, and this corresponds to an absolute scotoma. This can lead and predispose to CNV. And then you have category 4, which is macular atrophy. And here you have a well-defined kind of round grayish-white atrophic area that usually is around a regressed fibrovascular membrane, and this can enlarge over time. Then we also have plus signs, which are strongly associated with central vision loss, but they don't really quite fit into each category, and they can develop from or coexist within the category. So one plus sign is a lacquer crack, and you can see it's kind of these yellow, whitish, irregular lines, and they represent breaks in the membrane at the macula, and they can be associated with CNV formation. We also have choroidal neovascular membrane, which is the major sight-threatening complication in these patients. Overall, though, it is the most common cause of CNV in patients younger than 50 years old, so it is quite substantial. You have this grayish subretinal membrane with hyperpigmented borders, and risk factors include the patchy chororetinal atrophy, posterior staphyloma, and lacquer cracks, and it can be treated with anti-VEGF therapy. So this is one of my patients. The FA is at the top panel, and you can see there is late leakage of an active choroidal membrane. And then on OCT, the green arrow points to the active CNV, and you can get the subretinal and intraretinal fluid as evidence in the other arrows. You can also, another plus sign is a fugue spot, which represents kind of the scarring phase of CNV formation. And then lastly, we have posterior staphyloma, which is an outward protrusion of the limited area of the posterior pole. You have a shorter radius of curvature than the surrounding curvature of the wall of the eye, and this increases with higher axial length and with age. And this is associated with decreased vision, development of myopic maculopathy, and greater occurrence of CNV. So putting this all together, I went through all the different categories and plus signs. A large study of 800 eyes followed these patients over 12 years, 12.7 years, and they found that the overall progression of maculopathy, so that's within each individual stage or maybe, to the next stage, was actually really high. It was 40%. But if you break it down on the different categories, the earlier categories such as tessellated fundus only had about a 13% progression, whereas if you had choroidal neovascularization, almost 90% progressed to macular atrophy and severe vision loss. So factors associated with progression are age, severity, myopia, axial length, and presence of posterior staphyloma. And we know that the factors that are associated with worse vision are the development of CNV and macular atrophy. Other lesions of the posterior fundus include dome-shaped macula, myopic macular hole, traction maculopathy, and retinoschisis. This is one of my patients where you can see the red arrows are where the hyaloid is still attached at the edge of the posterior staphyloma, and the green arrow shows areas of retinoschisis where the hyaloid is still attached. There are other changes in the retina, including peripheral retinal changes. So we have lattice degeneration, retinal folds, and retinal tears. So in the top image is one of my patients who has lattice degeneration and has a break surrounding that. And then we also have another image of a MAC-off retinal detachment. And these can, of course, lead to vision loss as well. The last change I'd like to talk about is optic disc changes. We know that there are papillary and peripapillary regions that are distorted also by the mechanical stretching of the globe. So I think we can all, see in these patients, we have usually a tilted disc, and we have peripapillary atrophy. We can have acquired megalodisc, where the optic discs are larger and more oval. And this is thought that this can lead to higher susceptibility to glaucomatous optic disc changes. If you look at population-based cohort studies, even though no causal relationships are established, they've established that there are increased risks of glaucoma with myopia. The other factor is that because the optic disc looks a little bit more abnormal, glaucoma may be even harder to detect. So there are no, well-defined values of axial length that are associated with higher risks of glaucoma, but we do know it is associated. So in conclusion, pathologic myopia and its complications really rank near the top of causes of vision loss or blindness. There are limited treatment options for restoration of vision. So really myopia prevention and control, as we've been discussing all morning, is key. So thank you for your attention. I'd like to just give a special acknowledgement to my retina colleague, who I need to give credit for taking care of my patients with pathologic myopia. Thank you.
Thank you so much, Dr. Kang. Our last speaker is Dr. Ian Flitcroft, who is our Oliver Dabezies MD lecture, and the title of his lecture is Myopia Control, Think Before You Act. Dr. Flitcroft?
Thank you very much, and I hope you're all sort of surviving this. It's been a fantastic session so far, and I want to take a little bit of a different tack to what's been presented beforehand, which is actually just looking at the difficult corner cases rather than the best types of treatment. So in relation to disclosures, we have a range of academic and commercial support for our clinical trials and for equipment, and also involved in our university spin-out for analytics. But today we want to talk about concepts and not products. I've been thinking about myopia for a very long time. 23 years ago, I wrote a commentary that ophthalmologists should consider the cause of myopia, not simply treat its consequences. And this was a time when for most ophthalmologists, myopia was an opportunity to perform refractive surgery. At the end of this commentary, I made this sort of forward-looking statement that there's a real prospect of dramatic alterations in the clinical management of myopia. Now, if we fast forward 23 years to today, the question is, are we there yet? And 23 years ago, I hope I was an annoying little kid at the back of the seat, and I hope actually today I still am the annoying little kid at the back of the seat rather than the grumpy old man at the front. But we are pretty much there, but I regard where we are now as the starting line and not the finishing line. This meta-analysis I was involved with a few years ago, 2016, had confirmed that in clinical practice we now have a range of options which have effectiveness, as we heard today. And I'm delighted to say this slide is already out of date because it doesn't include the data from the DIMS lens and the Stellus lens, which are now showing that spectacle lenses too also have effective treatment. So I've used this, I don't know how clear some of that text is, but this diagram sort of is my sort of view of everybody sits somewhere on this, from people who are actually thinking that correcting makes them myopic, to people providing a comprehensive management plan on the right-hand side. And there's evidence that moves, from wherever you are on that curve, evidence to move you one step further down towards myopia management nirvana. If you're not correcting, good evidence that's not right. Single vision lenses, we now know they are the control group compared to the outcome. And we're trying to encourage people to start correcting. But there are a lot of people now providing comprehensive management who are suddenly faced with a different dilemma, which is, I've seen all the trials, but the person in front of me doesn't quite fit the box. What do I do now? And there's a massive difference between clinical trials and clinical practice. Clinical trials are based on average results. This is the type of person who goes into clinical trials, very cooperative and turn up. They're very restricted inclusion criteria. They exclude an awful lot of patients. And they have fixed protocols. We have over 350 kids on myopia control trials coming to our research clinic. And they're actually a very relaxing cohort because I don't have to make a clinical decision on any of them because it's all protocol driven. In my clinic, it's quite a different question because I have to make decisions on each individual patient. The clinical practice, rather than a clinical trial of 200 kids, is a clinical trial of n equals 1. You judge yourself and the parent will judge you on your success. The next patient doesn't know about inclusion criteria and they just want to be treated. And at every single visit, you have to make a decision about how we're going to treat this. And some of those complexities is why it takes 17 years from the sort of evidence we've heard today to actually getting it into standard practice. And we're certainly not in sort of standard deployment mode yet for myopia control. The question really is that what do you do when there is no evidence for your patient in front of you? You hit the end of the road. That's the question, obviously, think. And this is the alternative title of this talk, which is rational treatment planning for the weird cases. So an awful lot of these cases, as we've gone through today, wouldn't qualify for any of the clinical trials presented in that slide I showed you or that we've heard around today. But we do have a lot of data we can use. So rather than evidence-based in a classic randomized control trial Cochrane report, we can use a more old-fashioned clinical approach, which is knowledge-based. There's a lot of good normative data now being published about refraction, axial length, and keratometry to know as a benchmark. Risk estimation, a lot of good work has been done on that, and the paper I just want to mention to you that I think really sort of helps to summarize that in one place. We also have a great knowledge about conditions affecting the cornea, the lens, and the length of the eye. We're all trained up in appreciation of the optics, but thinking about that, how an eye becomes myopic is important. And particularly in sort of kids I see, awareness of syndromic and secondary forms of myopia. And when you are treating these kids, I'm very open to the parents to say, look, we have no proof this is going to work in this case. But I think it's worth trying. And equally reassure them that if it doesn't work, I have a plan B. And that combination generally is quite reassuring to parents. So the questions I think about, and this is quite a personal approach to how I manage these sort of kids, is that in every myop, rather than just thinking, am I going to use a subcontact lens, orthokeratometry, or atropine? These are high-level questions, which is, first off, how surprising is this level of myopia? And I look at family history, and I also use an age-based centile calculation tool that we've developed. I also want to know what's causing this level of myopia. Is this axial, is this corneal, or is this lenticular? And is this normal myopia, as I call them vanilla myopes, an ice cream analogy, or are they something more weird and wonderful to worry about? Next is how worrying is this level of myopia? And for that, I like to have tools to extrapolate what the final level will be and the implications of that, and also for axial lens. And one aspect which I'm really keen on, and I'm not quite sure is necessarily broadly accepted, is the concept that the question of how fast is this myopia progressing, either with treatment or without treatment, as compared to some benchmark data. So let's start off with a case. This is Miss Z, and actually the 4 cases here, if we get time to go through them all, which are, and they all actually, this bunch just turned up in my clinic 2 weeks ago, and some of them old, some of them new. But so Miss Z first came to me 2 years ago. She is extremely myopic, more than -8.5, which is pretty exotic for Ireland, and she's not an Asian patient. Her axial lengths are also eye-wateringly high. She's been in a center distance bifocal, which was prescribed by one of our very good myopia control optometrists we have locally. And as a start treatment, I will often start with that myself. In terms of causation, mother was emmetropic, father late onset myope, normal color vision, normal BCA. This next questions here on causation are my sort of run-through list, very good for sort of picking up issues in a very quick way, of night vision, hyperflexibility. There's 5 things you can do very rapidly in the clinic just for looking for connective tissue problems. I always look at their mouth. I always joke that it makes me feel like a proper doctor because I get my kids to say "ah" and I look at their mouth. Also looking at the gestalt of their face with dysmorphic for things like Stickler syndrome. A family history of retinal detachment, a cleft palate or heart valve surgery are also very good sort of non-worrying questions to pick up a lot of syndrome cases. So thinking about Ms. Z in relation to those questions, how surprising? Very surprising. In terms of population terms in Ireland, I mean, she's 99 point something percentile, and for axial length, she maxes out my calculations. What's causing this? There's no family history of note. There's no signs, clinical signs of myopia. But it's so extreme, there's probably a genetic component to it. How worrying is this? Her prognosis for loss of vision in later life, with the proviso we have 50 years to try to do something better than we do now, is significantly high. And where is she progressing? She's progressing by 0.75 doctors a year on treatment, and compared to her Irish peers, she's in the 68th centile. She's progressing significantly faster than normal. So let me just show you some of the data I use for that. So we've developed our own meta-analysis curves for centiles for refraction and axial length. Every parent is familiar with in Europe, and it's probably really familiar in America because their kids have been charged on this from birth. And it's a very quick conversation when you can mark up how extreme level of myopia this young lady is pretty much off the charts. In terms of risk and benefits, this paper I was involved with at Mark Bullimore-Led is published online, hasn't hit paper yet, paper form, but it's a summary of both the risks but also the benefits. And it contains, in terms of a couple of graphs which allow you to read off as an age, and you see this very strong interaction between increasing age and high myopia and the risk of multi-cause visual impairment, which gives you a sense of how worrying this myopia. We've collected a large amount of data, some real-world data from optometric practices. We have over 500,000 visits data from in Ireland and about 20,000 kids. So we've got pretty detailed data about what is progression like for myopia kids. And for this young lady, we can say that on treatment, she's progressing faster than normal, so it's in the red zone. And as indicated, most progression is 0.5 or less in the West. So that's an unacceptable rate for treatment. So I would regard it as a treatment failure, irrespective of her risk factors. So what am I going to do? I'm going to do what I sort of often do in this situation, which is I did this experiment. Particularly, I use 1% tricking my base there in non-daily lenses, so don't go for too long. If dilate them, ask for the lenses to come back in, and I check their near vision dilated with their myopia control contact lens, see if they can read, and they usually can. And then we jump on the basis of her extreme length and high risk profile already to the most effective evidence-based intervention, which is 1%. Hoping they'll tolerate it, but this experiment gives us a fair chance of that. All myopia control contact lenses, kids don't use the bifocal, multifocal element of it or increased depth of focus, but pretty much all designs I've tried so far, kids actually can use it with Atropine. I use that either weekly, twice a day, or once a week. And once a week, they're probably using the ad at the start of the week and maybe using the myopia control lens at the end of the week. What happened to this young lady with the worrying axial lens? Well, she started 27.3 and has barely changed in 2 years. And as has been mentioned already, that is actually that's a significant success because a normal 10-year-old would have grown by 0.34 millimeters from our benchmarks over this period of time. The question what I do next is unknown territory. I'm going to slowly reduce down and watch the axial lens like a hawk, but I'm hoping over the next few years we'll learn when to stop and when to wind down. But sure enough, we don't learn. Now, another interesting case, an 11-year-old girl who certainly wouldn't qualify for a treatment trial. She's referred, like most of my patients, please treat with 0.01% atropine, as the letter says. But usually end up not doing that. They're massively anisometropic, but those early screening questions pulled out a couple of features. She looked at the mouth, high arch palate. It was super flexible. And a strong family history of myopia. She's referred to atropine treatment, but in fact found some availability online and has just started treatment. Axial length, despite being minus almost 11, is only 24.63. That's a little bit longer for a 10-year-old girl, but not as long, and with no asymmetry. The asymmetry was all coming from her cornea, which was very steep, but very regular. Very pretty thick, so not exactly following keratoconic pattern yet. And my corneal colleague was watching rather than needing to intervene. So thinking about Miss V, how surprising is this? The asymmetry is super abnormal. What's causing this? This is a syndromic feature until proven otherwise, and the axial length is not the dominant factor. And how worrying? Well, theoretically, because the axial length isn't as long as you'd expect, we hope that we've got less than risk. And are they progressing? I've only seen them now in 2-month intervals and with a minimal change. So currently we're going to watch this like a hawk. But progression is not her big issue. Diagnosis is. This is a presentation format that we've developed, which is a mechanism map. It takes the axial length, cornea, and the lens, and calculates compared to an age-matched normal, what's contributing to myopia. On this right-hand side, you can see there's the blue arrow triangle is pointing straight to the cornea, and those little lines, you can see that the 2 and a bit is coming from the axial length, 2 and a bit is calculated coming from the lens ACD position, and 6 is coming from the cornea. And her fellow eye has a very unusual pattern, which is she's getting equal contributions from all 3. So how are we going to help? This girl does not need atropine. This is a diagnosis. So what we're doing for her is she needs gene testing for Marfan syndrome. She needs a cardiac echo because that's potentially life-threatening condition for in lots of these range of conditions. And we're going to monitor axial length very carefully, but also watch that corneal topography. So that the treatment for her, maybe more importantly, cross-linking rather than any other form of myopia control. Now, Master E is another interesting one. He's a kid, not super short-sighted, but he wouldn't qualify, say, for the MySight trial. What's surprising about him is keratometry, which will give you sort of a hint straight out of the gate that he's got flat cornea, so the myopia must have come from somewhere else. So this is a very long eye, and worryingly so for a child this age. What's causing is the family history suggests X-linked, but there's no strong factors there. And in terms of risk profile for axial length, he's worrying. And I've always seen him, so I haven't got definite, clear-cut cycloplegic progression, but he's certainly high up there. that same representation here, we can see in his, this triangle pointing straight to that. So he's getting more than a myopia generated from his axial lens than anything else. And this is a comparison to an entropic eye, just showing that emphasis of this kid is a super axial myope. How are we going to help him? I think we're going to push the parents, if they weren't keen already, or I would just bully them into that. And we're going to start contact lens first with a very low threshold for adding a second treatment. And the last case is a 10-year-old. He came in with reduced best corrected vision. Again, extreme, as everyone sends patients to me 5 years too late, unfortunately. Same screening questions. He's got poor night vision. Kids don't volunteer that very often. Often a surprise to parents. Very clear history of X-linked myopia. And again, depressing axial length. And fairly normal keratitis. But again, particularly high. What's caused this level of myopia? X-linked, reduced BCVA, and night vision. This is a retinal dystrophy or proven otherwise. And obviously worrying about this, we have no idea how an interaction between existing pre-existing vision and later myopia is going to work, but we have to assume that it's not going to help. His first priority for this kid is diagnosis, and this is ERG. So he was straight to, this is CSNB, this is congenital stationary night blindness, is one of those gloriously quick and easy diagnoses. So how are we going to help Master P and his family? He's referred to me for myopia control, but that really isn't the priority. He is moving to contact, so that gained a line division just from minification, which really helps these kids. Support in school, that's going to be transformative as well. And gene counseling for the rest of the family, particularly undiagnosed adults who are actually driving. There's always a few of those in these families. So a bit of a quick rush through it, but just trying to say that the thought process can help you actually make decisions, and you need to avoid the tendency that's, to hammer everything as a nail, that we just treat without thinking about what else can be going on. And the issue here is, while I've been very keen to get people involved in myopia control, we also need to start answering questions for people who have got there thinking, well, what do I do with this case? And give instructors for that. So these are the questions I'd like to leave you with, which is 4 questions to ask about every single myope. How surprising? What's the cause? How worrying are the implications of this? And what's the progression rate, either before I've treated or after, and how's that going to guide my analysis? Thank you very much.
Okay, thank you so much. Thank you, everybody, for staying on a couple more minutes. And that was an excellent lecture, not only our invited Oliver Dabezies lecture, but all the other speakers as well today. Thank you so much for listening and for joining us. And one more time, we'd like to thank our sponsors, Cooper Vision, Bausch & Lomb, Viluma, Alcon, and Johnson & Johnson for their sponsorship of the symposium today. On behalf of the ECLA, I'd like to thank everyone for joining, and enjoy the rest of your weekend. Thank you so much.
Thank you for attending. Have a wonderful day.